We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, Amogs Emergency Obstetrics Committee with Guntur, Nellore, Kurnool, Chittoor and Ongole Societies of Andhra Pradesh. And today's episode is 43. So it's my privilege to introduce the convener of today's webinar, Dr. V. Radha Lakshmi ma'am. Ma'am is the professor in Department of OBGY in SRMC Nandyal and also Secretary of Kurnool OBGY Society. Ma'am is also the Zonal Coordinator of NTRUHS AP and also in charge of Mission Pink Health and IMA Kurnool. I welcome you, ma'am.
Thank you. Good evening, all. So, welcome you all. So, introduce the other co-conveners also, Sahiti.
Yes, ma'am. It's my privilege to introduce the coordinators of this webinar, Dr. M. Devishri ma'am. Ma'am is currently working as a consultant in Jaya Hospitals, Rajahmundry, and also the Secretary of Rajahmundry OBGY Society from 2022 to 24. I welcome you, ma'am.
Thank you, Sahiti.
And it's my honor to introduce Dr. Monica Umbadan ma'am. Ma'am is consultant obstetrician and gynecologist at Mangalya Nursing Home and Atharva Fertility Center and also PAC Committee Chairperson Amogs 2022 to 24. I welcome you, ma'am, and I hand over the session to convener and coordinator.
So, good evening, all. So, welcome all to the 43rd Amogs webinar, 43rd Amogs Emergency Committee webinar, mainly organized by Sneha Madam. I want to start the program with the prayer song. Please, Sahiti.
Sahiti, please play the invocation video.
So, let me start the program with the introduction of our main organizer of this program, none other than Sneha Bayer Madam. She did her MBBS MD from BJMC Medical College, Pune, Managing Director of Suktara Hospital, and 32 years of experience in the field of OBG, teaching experience of 5 years in the SVN Government Medical College, and she is the main candidate for the Vice President post Foxy West Zone, election year 2025 and 26. She is having many awards and applauds, and her official post she held were Chairperson Breast Committee Foxy 2019 and 21, Governing Council Member ICOG 2021 and 22, Chairperson Medical Disorders Committee Amogs 2022 to 24, Founder President Vidarbha ISOPAP 2017 to 19, President Yavatmal Obstetric Gynec Society.
Dr. Radha Lakshmi.
Yeah.
Thank you for that kind introduction.
I request Madam to introduce PK sir.
Yes. So a very good evening to one and all. My respects and regards to all the seniors here. At the outset, let me welcome and thanks to all the respected chief guests and guest of honor, Dr. P.K. Shah sir, and of course Dr. Kiran Kuttakoti, and guest of honor Dr. Murlidhar Pai and Dr. Yashoda Pallam Reddy. I would like to also welcome and thank all the president and secretaries of Kurnool, Nellore, Chittoor, Ongole, and all the societies of Andhra Pradesh. I would like to thank the president and secretaries, and I'd like to welcome and thank the
Madam, you are not audible, Madam. Sneha, Madam.
She is not there. I think she has lost we have lost her connection. She's not there right now. Sneha is not there. I think she has dropped off. The internet has dropped off.
So let me introduce.
Yeah. She's coming back. She's just joining, I guess.
Hello.
Yeah, Madam.
So sorry, it's raining here, and that's the reason I think the problem with the network. Just changing the
Madam, you close the video, madam. Then the audio will be good.
Yeah, no, I have changed the network itself. Can you see me?
Yeah.
Okay, so I think, a very good evening to all of you once again, and I welcome all of you. I take this opportunity to welcome all the faculties, especially the speaker, Dr. Sridevi and Dr. Shobha Gudi. And I also welcome all the chairpersons, Dr. Venkatramana, the president of Kurnool Society, Dr. T. Srilakshmi, Dr. Sheshasai, president of Chittur Society, Dr. Venkateshwar Rao, President of Guntur Society, Dr. Aruna, President of Ongol Society, Dr. Uma Shankar, the Secretary of Guntur Society, and of course, the other chairpersons and panelists. I would also like to welcome the expert for this panel discussion, Dr. Mangalavani and Dr. Aruna Kumari, who is the past president of Rajamundry Society. I would like to welcome and thank the esteemed panelists, Dr. Lalita Shridisha, Dr. Vignata, Dr. Baby Shalini, Dr. Suprada, Dr. Pandala, Dr. Anita, Dr. Shirisha, and Dr. Sudharani. So, with this brief preamble, I would just give you a preamble saying that, fourth trimester is the most neglected aspect till now. We are not discussing much about it, though we are just talking about the emergency obstetrics. And that's the very reason we have selected this topic. Maybe a little different from the other topics, and we just hope that all of you are benefited with this. We're trying to cover all the aspects of fourth trimester. With this, I would like to invite and introduce respected Dr. P.K. Shah, sir. Sir, can you please display the CV? Whom I think nobody needs a formal introduction for P.K. Shah, sir. Actually, sir is a very well-known figure in the field of academics, I would say. So he's the past president of Foxy, IIG, IFU, MOGS, etc. And sir has got lots of
enough.
Please, sir, we are very eager to listen to you and have your blessings. Over to you, sir.
Thank you very much for your kind introduction. And it's a great pleasure to be with you all during this Amogs Emergency Obstetric Committee event, the webinar, along with all the office bearers, especially my dear friend Dr. Kiran Kurtukoti, Dr. Vipin Pandit, Dr. Rajendra Singh Pardesi, and the chairperson of Emergency Obstetric Care Committee, Dr. Sneha Buyar herself. Also, I'm very happy to see that you have two guests of honor, Dr. Muralidhar Pai and Dr. Yasoda. Dr. Radha Lakshmi, the convener, Dr. Devi C and Dr. Monica Umberland as coordinator, and very good speakers in the form of Dr. A. Sridevi is going to cover puerperal sepsis, and Dr. Shobha Gudi will be covering postpartum contraception. And then Dr. Sneha will be conducting the panel with two experts, Dr. Mangalavani and Dr. Aruna Kumari, and almost 8 panelists. So the selection of these topics is superb, especially postpartum contraception and the breastfeeding, which is very close to me. I'm sure all those who have joined today will be benefited with this webinar, and I wish Sneha all the very best for all her future endeavors, and I wish her success for the Vice President's post from West Zone for the election year 2025. Sneha, I have to go somewhere and I shall take your leave if you don't mind. Thanks a lot and wish you all the very best for all your future activities. Thank you.
Thank you, sir. Thank you so much for joining in spite of your busy schedule, sir. Thank you so much for blessing me always.
Thank you.
Thank you, PK sir.
Anji, thanks.
Thank you, sir.
So with this, I invite Dr. Radha Lakshmi now to invite and introduce Dr. Kiran Kurtukoti, Amogs President.
So it is my proud privilege to introduce Kiran sir.
Radhaji, thank you. Thank you so much. Thank you so much.
So, sir is very famous as an endoscopic surgeon
No, it's okay,
And,
Dr. Radha.
not only that, he under his guidance, many became super specialist in endoscopy. Sir, I know you as a great endoscopic surgeon.
Thank you.
And making many to become endoscopic surgeon.
Thank you so much. Thank you.
Of India.
Yeah.
Thank you, sir. Thank you.
Thank you, Dr.
So,
Radha.
and
Thank
I
you.
request you to tell few words of your wisdom.
Yeah.
Welcome, sir, Dr. Kiran Kurtakoti.
I'm already eager to tell you, Doctor. Anyway, thank you. Thank you on behalf of Amogs. A warm welcome to all of you on Amogs platform. And really, I would like to acknowledge the presence also of Dr. P.K. Shah, Dr. Murlidhar Pai, Pranam, Dr. Yashodha Pallam Reddy, Madam. And of course, my friend from Pune, Dr. Mangalavadi, Professor Sridevi, Madam, Sneha, Dr. Radha, everyone. So indeed.
So for all of you, my name is Yashodhara. All of you are calling me Yashoda. Yashoda is Krishna's mother. I am Buddha's wife. Yashodhara.
Yes, madam. Madam Yashodhara, thank you so much. Yeah. As you rightly said that the fourth trimester is one of the most important trimester. You know, we have been telling about this anemia, go back anemia, chale jao movement since about say 20 years or so. But anemia is here to stay, and I believe that probably the fourth trimester is the one of the most neglected trimester, which is one of the most important causes of that. Of course, peripheral sepsis again. Sepsis-induced coagulopathy is again coming up in a very, very big way. So that is also a new topic which needs to be addressed too. Thirdly, puerperal psychosis. Yes, mental health in the puerperal is going for a toss, probably because of anemia, probably because of B12 deficiency, probably because of nuclear families and n number of factors. And you know, the issue of lactation has cropped up in such a huge extent. Thanks to people like Mangala in Pune, we are having excellent lactation consultants. But you know, this problem has cropped up in such a way that we did not even imagine 10 years or 15 years back that could be an issue when it comes to puerperal. But again, that's a very big problem. And thank you, Dr. Sneha, for addressing all these issues. Really, you have been phenomenal in your work. In your work as the EMOC committee chairperson of Amogs. I think this is probably my 1000th webinar that I am attending. So really, a special medal should be given to you. So thank you so much, and I acknowledge presence of Professor Pai. Thank you, sir, for being here, and thank you for being in Amogs. I see that your background is Sikkim. I don't know whether it is a virtual one or a real one, but if it is a real one, I really envy you.
This is virtual, sir.
Yeah. Anyway, so thank you so much, and thank you. Be there with the Amogs, and I see 3 or 4 people who are contesting. Sneha, of course, is one of them. Monica and Dr. Radha. So best wishes from Amogs side.
Thank you, sir.
Dr. Pallam Reddy, thank you. This is the first time we are meeting in Amogs platform, so most welcome, and we definitely would like to hear from you always. And I also noticed my good friend Dr. Shobha. I don't think Shobha is there, but she must have left. So
no, I am here.
Okay. I think you
I'm very much here. Yeah.
Thank you. So,
thank you, Kiran, for having me here. Thanks a lot.
Shobha Gudi also. So, thank you. Best wishes to Dr. Sneha, and I would wish that the program gets on well. And thank you so much. Namaskar.
Thank you, Dr. Kiran. Thank you so much. And may we invite Dr. Monica to introduce our guest of honor, Dr. Murlidhar Pai, sir. Welcome, sir.
Thank you, Sneha ma'am, for the opportunity to coordinate. I take privilege in introducing our guest of honor, Dr. Murlidhar Pai, sir. He is the Dean of Sikkim Manipal Institute Medical Sciences, Sikkim. He is a professor with 37 years of academics, 22 awards, and 15 international fellowship. Almost everybody in Foxy, sir, is a fan of your videos, of your lectures. We welcome you, and we request you for a few words of wisdom, sir.
Thank you very much for inviting me for this very important webinar. As Kiran sir said, Dr. Sneha has been conducting these very useful academic sessions for so many years now. And my problem today, actually, I am in a meeting still, but very difficult to refuse to Dr. Sneha's invitation. That's why I have accepted this. In fact, she wanted me to give a talk, but I said today, since I'm busy, I would like to just come and wish this program very well. I'll be talking on 9th for another webinar, what she's going to conduct. So wish you all the best for this webinar. Thank you.
Sir, thank you so much, especially for joining, from your busy schedule. Thank you so much. Thank you. Yes, maybe
Yes,
request Devi Shri to introduce Madam Yashodhara Pallam Reddy. Do we have Devi Shri? So, yeah, we welcome Madam Yashodhara Pallam Reddy.
Thank you so much.
Privileged to have you, Madam, and we are eager to listen to your precious words. Over to you, Madam.
Thank you so much. I'm sorry I forgot to send you my CV also. I'm so sorry. So for everyone, I'm the founder president of Nellore Society. Of course, I have other small. I was president of Rotary. All those small things are there. So I'm very much interested about these breastfeeding programs and all. It's really good because the concept of breastfeeding when I was student is totally different from now. Even though we are starting early, during those days when I was student, they used to say that exclusively, even for 24 hours, even if the patient is not getting properly sufficient milk or not, she has to feed only breast milk. But now we are adding little of top feeding also for a day or two till she properly gets her breastfeed. So that's how I am practicing in my area, because definitely it is not sufficient for the baby first day if she is not getting properly, because they will be dehydrated and they will be not well nourished on first one, whether it is normal or C-section. So this is the one I really, in my practice perspective, I want to highlight all of you. And puerperal sepsis, of course, such things, they are very important. Puerperal sepsis leading to death or complications, such grave complications, we really don't expect in, high-end population like middle class and upper middle. Because in government hospitals, still they are really grave complications. We still are getting it, I think. Even in Nellore, we are getting such complications, but they became extremely rare, I think. I don't know how far you are getting cases in North. So, but it's even though we don't get it day in and day out, but this is a very important topic regarding sepsis. So it's very nice. Of course, when I am remembering my student days when I was postgraduate, so Tillin's last chapter was puerperal sepsis. It was beautifully mentioned there in Tillin's last chapter. So all those pathology, all those things, I really enjoyed reading all those things. So now it's my privilege to meet all of you. Some people first time, and I wish Dr. Sneha and Karnool, our Dr. Radha Lakshmi. So whoever is contesting, all of you, wish you all the best. Whatever best we can do, we try to support you, and we try to help you. Wish you all the best for your next endeavors. Thank you so much, all of you. Enjoy the webinar.
Thank you, madam.
Thank you, madam. Thank you so much for taking time out of your busy schedule, and thank you for those wonderful words. Thank you so much. Radha, you can just give vote of thanks, and I think we would go ahead with the academic session.
So I sincerely thank Kiran sir, Yashodhara madam, Mangalavani madam, and other chairperson, P.K. Shah sir, Murlidhar Pai sir. So for your words of wisdom, we'll introduce the chairpersons of the first session. So Dr. Venkatramana sir. So Dr. Venkatramana sir is
I think the coordinator.
Monica, please.
Yes, ma'am, I'm there. Let us introduce the first academic session, that is topic of puerperal sepsis, which will be taken by Dr. Sridevi ma'am, the Associate Professor of GMC Ongole. The chairpersons for the session, Dr. Venkatramana sir. Sir has more than 25 years of service in Kurnool Medical College as Professor, Associate Professor and retired HOD. He is presently working as a professor of the OVG Vishwa Bharati Medical College at Kurnool. He has earned more than 50,000 DPL surgeries. Sir has been the KMC alumni and IME Vice President. We welcome you, sir, as a chairperson for this session. Our next chairperson, Dr. Sri Lakshmi, madam. Madam has a vast experience of over the last 18 years, and she has worked as a chief consultant for Medicover Hospital, Nellore for the last 6 years and Vijaya Hospital for last 2 years. She has worked as a past treasurer of NOGS and now is the vice president of the same society. We welcome you, ma'am. Our next chairperson, Dr. Sheshasai sir, also holds a PG diploma in human rights from the SMA University, Tirupati. He has worked in the army as a captain for the last 5 years and the NSS program officer at SV Medical College, Tirupati. He is currently working as an associate professor at the Government Maternity Hospital, SVMC, Tirupati. We welcome you, sir. I request the chairpersons to please introduce our speaker, Dr. Sridevi madam.
Dr. A. Sridevi is the student of Kurnool Medical College. Now she is working with associate professor in the Department of OBC, Ongole, and she is very good orator, and we know her since from the PG period. I welcome Dr. Sridevi to go on with the lecture.
Over to you, Sridevi ma'am, for your talk.
Yes, ma'am. Ma'am.
Yes, ma'am.
Good evening, all the senior members, ma'am, my teachers, Radha Lakshmi ma'am, Venkatamna sir, and Sneha Biyar ma'am, and all the secretaries and presidents, and all my dear friends. Thank you very much, ma'am, for giving me this opportunity. Today we will discuss regarding the puerperal sepsis, the 4th trimester. This is the first time I have heard ma'am, 4th trimester. So the important topic today we are going to discuss is the puerperal sepsis. As we know, the puerperal sepsis, it is defined as developing after birth until 6 weeks postnatally, and here the most common organism causing this is the GAS, that is group A hemolytic streptococci. And until otherwise proved, we should think of the cause of sepsis in the puerperal should be from the genital tract. Next other causes should be ruled out. So it is one of the important cause of maternal mortality, and it is causing organ dysfunction with a mortality of 20 to 40%, rising to around 60%. So coming to the simple definitions of sepsis, infection plus systemic manifestation is called as sepsis, and severe sepsis is sepsis plus sepsis-induced organ dysfunction or tissue hypoperfusion. Septic shock means persistence of the hypoperfusion despite adequate fluid replacement therapy. So these are the 3 definitions of sepsis. Next, coming to the genital tract sepsis, may be present with a severe abdominal pain and tenderness, unrelieved by usual analgesia, and this should prompt the urgent medical review. Madam, next slide, ma'am. Identification and assessment of evidences. Most commonly, group A streptococcal infection has been isolated. Other organisms like E. coli, Staphylococcus, Clostridium velicae are also present, ma'am. Next, ma'am. So coming to the risk factors for this sepsis, obesity is one of the risk factors. Obesity, impaired glucose tolerance, impaired immunity, anemia, vaginal discharge, and any history of pelvic infection, amniocentesis or other invasive procedures, cervical cerclage, and if she is having prolonged spontaneous rupture of membranes, vaginal trauma, that is including episiotomy wound or cesarean section at the time, and also wound hematoma, any retained products of conception, and GAS infection in close contacts or family members, black or minority ethnic group origin. These are the few risk factors. The organisms, as I told you, causing the sepsis are mainly the group A streptococcus, that is Streptococcus pyogenes, E. coli, Staphylococcus aureus, Streptococcus pneumoniae, and also methicillin resistant Staphylococcus aureus, Clostridium, and Morganella morgagni. And the sepsis outside the genital tract, the causes what we should think of is the mastitis. Simple sometimes, if it is overlooked, it may lead to breast abscess formation, necrotizing fasciitis, and toxic shock syndrome caused by the Staphylococcus aureus. And another important cause what we should think of is the urinary tract infection. Sometimes it may lead to acute pyelonephritis, which she presents to you with severe loin pain or abdominal pain. Pneumonia mainly caused by Streptococcus pneumonia, where she presents to us with an upper respiratory tract infection. And skin and soft tissue infections may be leading to, ultimately it may lead to necrotizing fasciitis. And gastroenteritis, she may present to us with nausea, vomiting and diarrhea. And pharyngitis and infection related to regional anesthesia. Sometimes it may spinal abscess may form, that may be the cause for sepsis. So coming to the signs and symptoms of sepsis are fever, chills and rigors, diarrhea, vomitings, breast engorgement and redness may be there, rash, abdominal and pelvic pain, and wound infection spreading, that is cellulitis or discharge. And some offensive vaginal discharge, productive cough, urinary symptoms, and there will be delay in the uterine involution, that is subinvolution, and she may be having foul smelling lochia. And sometimes non-specific signs, she may be lethargic and reduced appetite may be present. So some causes of sepsis in the purpurium may be present initially only with severe abdominal pain in the absence of any fever and tachycardia. So any widespread rash should also suspect the toxic shock syndrome. Any generalized maculopapular rash in most of the cases of Staphylococcus toxic shock syndrome may be present. Conjunctival suffusion may also be the classic sign of toxic shock syndrome. So, how to monitor these women with the suspected sepsis? So, regular observation of all the vitals, including the temperature, pulse rate, blood pressure, respiratory rate, should be recorded in the modified early obstetric warning score chart. So, the red flag signs, as I told you, pyrexia of more than 38 degrees centigrade and sustained tachycardia more than 90 beats per minute, breathlessness with respiratory rate of more than 20 breaths per minute, abdominal pain, chest pain, diarrhea, vomitings, uterine or renal angle pain and tenderness. And if the woman is unduly, she is dull or anxious or distressed, these are the red flag signs of sepsis, which prompt the hospital admission after delivery. Early presentation of sepsis less than 12 hours after birth, it is likely to be caused by the group A streptococcal infection. And here she may be having severe continuous pain suggesting the necrotizing fasciitis. Or she may also present to us with persistent vaginal bleeding or abdominal pain. What we should suspect the infection. So coming to the investigations, the important investigations are bed cultures are the key investigation that should be obtained prior to the administration of antibiotics. Serum lactate levels should be measured within 6 hours of suspicion of sepsis, and lactate levels more than 4 millimoles per liter is indicative of tissue hypoperfusion, and any relevant imaging study should be performed in an attempt to confirm the source of infection. So that may include the chest X-ray, pelvic ultrasound, CT scan if your pelvic abscess is suspected. So other samples may be taken if you are having a clinical suspicion of any focus of infection. Routine blood test should be taken. Next, any woman symptoms of tonsillitis or pharyngitis, we can take a throat swab for culture. And if MRSA status of the woman is not known, we can take the nose swab. Pre-moist and nose swab can be sent for screening. Blood cultures and other samples should be guided if there is a clinical suspicion of focus. So, task to be performed, this is the sepsis 6-care bundle, what should be followed as I previously mentioned in the slide. First, we have to obtain the blood cultures prior to administration of antibiotics. Administration of broad spectrum antibiotics within 1 hour of recognition of sepsis. Next, measure the serum lactate levels. If the lactate levels are more than 4 millimoles per liter in the event of hypotension, we should deliver a minimum of 20 ml per kg of crystalloid or an equivalent, and apply a vasopressor for hypotension if it is not responding to your initial fluid resuscitation to maintain the mean arterial blood pressure above 65 mm of Hg. Next is in the event of persistent hypotension despite the fluid resuscitation, that is septic shock, or when the serum lactate levels are more than 4 millimoles per liter, achieve a central venous pressure of more than 8 mm of Hg, achieve central venous oxygen saturation of more than 70%. So these are the components of the sepsis 6-care bundle what we have done. And coming to the management, the antimicrobial choices and some limitations of the antibiotics which will be given in the puerperal sepsis is co-amoxiclav. It does not cover the MRSA, and metronidazole that only covers the anaerobes. And clindamycin, the antibiotic, it covers most of the streptococcus, staphylococcus, including the MRSA, and it is not renally excreted or nephrotoxic. And piperacillin, tazobactam, and carbapenems, they cover the most of the organisms except the MRSA under renal sparing. And piperacillin tazobactam does not cover the extended spectrum bacillus beta-lactamase producers. So gentamicin is also given as a single dose of 3 to 5 ml per kg. It does not pose any renal function problem. So these are the few antibiotics which can be given. If the woman is having infection, sometimes the focus of infection should also be dealt with, especially if there is any pus, we have to drainage. That is drainage of the breast, wound or pelvic abscess. Broad spectrum antibiotics should be given to cover this. So what antibiotics should be given is mainly broad spectrum antibiotics covering these organisms within 1 hour of suspicion of sepsis should be given. Combination of piperacillin and tazobactam with carbapenem or clindamycin provides one of the broadest range of antibiotics for severe sepsis. If MRSA resistant to clindamycin, then we can go with the vancomycin, that is a glycopeptide, or teicoplanin that may be added until sensitivity is known. Breastfeeding may limit the source of these giving antibiotics, so we may take the consultation of a microbiologist. Should be sought at this stage. Antibiotics therapy for guided for gram-negative staining after aspirate also should be given, and also broad spectrum antibiotics. Sometimes if the patient needs within 1 hour of sepsis, we should go for intravenous antibiotics. Antibiotics should be started. Coming to the newborn, the care should be taken is, especially if the woman is having the sepsis during the birth or after during breastfeeding, the umbilical area should be cleaned, and the pediatrician opinion should be taken in the event of sepsis in the purpurium. If either of the mother or baby is infected with the invasive GAS in the postmortem period, both of them should be treated with the antibiotics. And the role of immunoglobulins here is, the immunoglobulins is recommended for severe invasive streptococcal and staphylococcal infections if other therapies have been failed. And these immunoglobulins, they have an effect by neutralizing the super antigen effect of exotoxins, inhibit the production of tumor necrosis factor and interleukins. So coming to what are the indications for admission for ICU in the case of sepsis is, in the cardiovascular, if she is having hypotension with raised serum lactate levels, if she is having any respiratory pulmonary edema, if she needs mechanical ventilation or airway protection, if she needs renal dialysis or neurologically significantly decreased conscious levels, miscellaneously if she is having any multi-organ failure, uncorrected acidosis or hypothermia, these are the few indications for admission to the ICU. So can the sepsis in the purpurium be prevented or detected earlier? All the pregnant women and recently delivered women should be informed the signs and symptoms of the genital tract infection and how to prevent its transmission. Any gas infection, that is a GS, group A streptococcal infection identified during pregnancy, should be treated aggressively. Thank you, ma'am.
Thank you, Dr. Sridevi. We have covered entire thing in the regarding the sepsis, puerperal sepsis. I think almost entire topic is covered. Okay. Now, Sneha madam.
Thank you, sir. Thank you, sir.
Sneha madam, I wish all the best for your success in the election year. And one more thing, personal request, kindly help the Kannur Society, because Dr. Radhalakshmi is contesting for the chairperson post. So I request all the presidents and secretaries, whoever in this group, kindly help the Kannur Society to get the post in the elections. Thank you. Thank you, one and all.
Thank you, sir. Thank you, sir.
Thank you, Venkatramana, sir. So
Sridevi ma'am, thank you for an exhaustive talk on puerperal sepsis, and Venkataraman sir, thank you for chairing the session. Is Dr. Devishri here?
Thank you, ma'am. Monica, ma'am.
Yes, ma'am. Should I continue with the second session, or should I wait for Dr. Devishri to come?
Ma'am, I'm here, ma'am.
Yes, ma'am. You can start introducing the chairpersons of the second session, please.
Yes, ma'am. Second session, topic 2, postpartum contraception. Our speaker is Dr. Shobha Gudi, ma'am. Now, I would like to introduce our first chairperson, Dr. B. Venkateshwara Rao, sir. Sir is president for Guntur Roji Society. Sir is a professor and HOD of Guntur Medical College. Sir, field of interest is high-risk pregnancy and infertility. Sir is president for APOG, 2019, Organizing Chairperson State Conference APCOG 2019. And sir conducted many CMEs and workshops, presented many papers in national and state conferences, many publications in international and national journals. Sir is also an examiner for UG and PG and in various South Indian universities. And he also participated in many social health programs. Sir is a past IMA member Guntur branch and conducted many training programs in national and state level. Sir is also a university player in TT and cricket. Welcome you, sir. And I would like to introduce our second chairperson, Dr. N. Aruna ma'am. Sir, ma'am is a senior obstetrician in Ongole at Nalluri Nursing Home, Ongole. Our third chairperson, Dr. Uma Shankar sir. And sir has done his diploma in laparoscopy surgery, diploma in IVF at Kiel University, Germany. Sir is an endoscopic surgeon. Sir is also very well known to us. He is very active in all the activities, not only in AP, but also in nationwide. Sir is a clinical head and infertility specialist at Ahalya Hospitals, Guntur, Andhra Pradesh. Sir is a joint secretary in Guntur OG Society. Sir is also a secretary at Amogs, executive member in AP ESAR, organizing secretary with 5th AP COG. Sir has won awards like Jagdishwari Mishra National Award for the best poster presentation at Cochin in year 2006 and won the same award for the best poster presentation at Mumbai in 2013. Sir has also won Indian Greatest Leader Award in the year of 2016 and 17. Sir is an inspiring gynecologist and IVF of India Award 2019. We welcome you, sir. Now, I would request one of our chairpersons to kindly introduce our speaker, Dr. Shobha Godi, ma'am. Sneha, ma'am.
So, Devi Shri.
Ma'am.
Myself, I will introduce Dr. Shobha, madam.
Okay, ma'am. Okay, ma'am.
Madam did her, madam is well-known person from South India. And she is the professor and HOD of the Department of OBG in St. Philomena Hospital, Bangalore. She is the author of Foxy Focus GCPR and publications many in at national and international level, and GCM ICOG 2021, 22-23 and 24-25, peer reviewer of Jogi ISAP, national corresponding editor Jogi 2024-26, and madam also contesting for the post of vice president from the south. And madam is a past chairperson of contraception and reproductive health ISAPA, chairperson endocrine committee IMS 2024-26, South Zone coordinator SBSI, EC member Kasoga 2021-23, board member FPAI, president BMS 2022-23. So I request madam.
Radha, yeah, thank you so much. Thank you. That's a very kind introduction we had. I hope I have been enabled to share. Yeah, thank you so much. Yeah. So at the outset, Radha, thank you very much. And it is wonderful to meet you on the virtual.
So we met you personally also many times, madam.
Ma'am, you are on mute. Kindly unmute, ma'am.
Yeah. Now is it okay?
Yeah.
Yeah. So let me thank at the outset Dr. Sneha Bhuyar, who is instrumental for bringing me here to this webinar. And of course, my really deepest gratitude to Dr. Kiran Koti, the president of Amogs, and Dr. P.K. Shah sir for being here. And of course, to my dear friends, very good evening to Muralidhar and to Yashodhara. And it is a pleasure, privilege to be here. And I felt that it was very important that we discuss these matters. But before I begin, let me first congratulate Sneha for having been such a champion for the cause of women's health. And now that she has taken up this crusade of the 4th trimester of pregnancy, I'm sure that this will go a very long way. Sneha has been relentlessly working for the cause of women's health, especially in matters of breastfeeding, of course, as a chairperson, but even otherwise, I have found her very, very progressive in thought, and she really deserves what she is aspiring for. So, congratulations, Sneha, on your perseverance, and I wish you all the best for the upcoming election. And I hope that you do succeed. My best wishes for Dr. Radha Lakshmi, and we being to some extent seniors in Foxy from the south, we are delighted to witness that more and more interest is being generated amongst Foxians from the south to take up chairperson's post, and we welcome you, and definitely we are going to support all candidates from the south. To do some justice to this very vast subject of postpartum contraception and family planning, let us first understand how it has been defined. Now, today, it is the prevention of unintended pregnancies and closely spaced pregnancies throughout the first 12 months following childbirth. So, postpartum is not restricted to 6 weeks or 2 months or 3 months. In fact, it is an entire year after the birth that we need to look for opportunities to prescribe contraception to delay the next pregnancy. Traditional this thing definition has therefore changed, and it has got extended to 1 year. And the reason behind this was the high unmet need in the first year, which has not changed greatly over the year. Even in the current NFHS 19 and 20, it remains around 55 to 60%. And it's widely proclaimed that it is up to 65% unmet need in the first year for limiting and spacing methods both. And it is widely acknowledged that at least 1/3 of women become pregnant after birth within the first year. Hmm? And maybe 34%, that means almost 30 to 40%, will actually deliver in the next 6 months as well. So it is a little disheartening that when we provide a very, very meticulous antenatal care, we do not give enough focus on delaying the next pregnancy, and that should come spontaneously from our consultants. And that is why the need for this lecture. And I'm very grateful that I'm able to deliver this very, very brisk lecture. Please pay close attention. I'll go a little fast. So for some reason, my name is shown as Suprada here. So please acknowledge that I am Dr. Shobha Gudi. I don't know why I failed to change my name. So what is the timing of postpartum family planning? So it can be post-placental as early as immediately after expulsion of placenta within 10 minutes of birth, or it can be 48 hours, or it can be in 6 weeks, or it can be 6 weeks to 1 year. And therefore, up to 1 year, there is a chance of counseling for healthy timing spacing of pregnancy and the great benefits thereof. And what is important is to counsel during the pregnancy, especially for postpartum IUCD. And why is this intervention very important? Because I think it can avert, family planning can avert a lot of maternal mortality and morbidity, as well as child mortality and morbidity. And if the spacing is more than 2 years, and closely spaced pregnancy definitely lead to very poor outcome for the baby. We know that. And also maternal mortality statistics are show very clearly that 90% of abortion related, 20% of obstetric related mortality, morbidity is actually can be averted if the pregnancies are delayed. All right. So interbirth interval of more than 2 years is what should be the aim. And this has been proved in several developing countries across the world, including Kenya. The key content, therefore, today is healthy spacing, and we must always tell them not just spacing, but you add to it healthy spacing. So when the word health is added to spacing, it has a different impact on the family. Mother's risk for unintended pregnancy after birth should be well known. We must all know that the LAM period, or the lactation amenorrhea period, can transit at any time. It is unpredictable and ovulation therefore can occur. And there are methods which are very safe for even the breastfeeding postpartum women. And discussing choosing a family planning method within the first month postpartum, couples communication is of vital importance, and importance of the services and referrals are very, very important. So we do have a wide array of basket of choices to be offered in this situation, and we must have the charts like this which compares typical effectiveness of contraceptive methods, and we can see that the long acting methods are equally effective to the limiting methods of sterilization, etc. And we must at all times promote LARC methods as well as hormonal contraceptives because they are highly efficacious. This is a good chart from WHO which identifies the methods in context of the postpartum period. And it's very clear to see that while immediately after birth, it is possible to, for the man to go and get vasectomy done, of course. And, the lactation amenorrhea method is in place. For breastfeeding women, progesterone only methods can be actually started. For non-breastfeeding women, the combined OC pills can be started earlier, but in breastfeeding women, the combined methods come after 6 months. The barrier methods can be used earlier. Emergency contraception can be used at any which time. And following 6 weeks, injectables and other progesterone only method like even the LNG IUS can be considered. And immediate postpartum, you can see that IUD has a place, intrauterine device, in 48 hours, a copper baric IUD, and after 4 weeks. So immediately effective is the lactation amenorrhea method and post-placental insertion. We have spoken about this, female sterilization within 7 days or after 6 weeks. No, preferable not to do it in between. Barrier methods can be widely followed, and women has had 3 regular cycles, or she can prevent pregnancy by avoiding during the 8th to 19th. So even the rhythm method can be followed once regular cycles are there. So natural methods also have a role. So couples who are reluctant to opt for the other methods, modern methods, can practice natural methods also. We have spoken about hormonal contraception in the previous slide. This will be a little repetition if I say that the COC, if not breastfeeding mother, then 3 weeks, if breastfeeding mother, then 6 months, and progesterone only methods like pills and injectables 6 weeks after childbirth, and immediately if not breastfeeding. Category should be remembered. The 1, 2, where there is no restrictions. 2 is advantages outweighing risks. 3 is risks outweighing advantage. Category 4 not to be used. And this is the tool, a very, very precious tool like the MEC category wheel or MEC criteria wheel, which will help us to offer almost 2000 recommendations for almost 25 methods. So even women with pre-existing problems, medical conditions, or other health problems we will be able to give them some basket of choice. Okay. So one should always remember that the MEC criteria was initially designed to provide safe criteria for combined oral contraceptive pills, but then it has been extended to other methods as well. And the back of the pill contains information like this, which helps us to do a fine tuning of the prescriptions. So here the red is showing selected methods, the green box is showing the medical or health conditions, and the yellow in the center is showing the MEC category. And it's very easy to have this Bitzer's triad of these 3 components of prescription to fit together to offer a basket of choice. And wherever you find an asterisk here, you will be able to turn the disc and look here as to what the asterisk means, and you will be able to complete the prescription. So the question in postpartum women often comes because we have been told that amenorrhea is actually very good method, the lactation of contraception. Yes, is it good enough? It will be good if all factors are followed. For example, if she is exclusively breastfeeding, then till 6 months it is fine. And if she is only partially breastfeeding, then she may become pregnant. So the Bellagio's criteria should be followed that she is exclusively breastfeeding, she remains amenorrheic, and she is within 6 months of birth, then only it is effective and the incidence of pregnancy is very less. And this infographic from WHO website can be downloaded and you can keep it in your postnatal wards so that it gets easily explained to the mother. So we have an unplanned pregnancy in a 25-year-old woman who has delivered 11 months back, and she had only sorry about that, she had only two periods since then, and then following that she has conceived. So then, and she is amenorrheic. So in such a situation there will be some doubt as to whether she is pregnant, so you quickly put her to the question, because there will always be a time when a pregnancy exists in the absence of a positive pregnancy test. That is the window period for implantation, where fertilization has occurred but implantation is too early or has not happened, and then we get a negative test. So we can ask her if she had her last monthly bleeding within the past 7 days or intercourse since her last monthly bleeding or since her delivery, if she has been following a reliable method or delivered within the last 4 weeks or delivered the baby in 6 months and she's fully breastfeeding and amenorrheic, or has had a miscarriage in the past 7 days. And if it is no to all of the questions, pregnancy cannot be ruled out using the checklist. So rule it out by other means, which may be wait for some days and then repeat the pregnancy test, or tell them that if they opt for a method, they should come back if the period does not return, as pregnancy may be there. But if she answers yes to at least any one of these questions, then you are sure that she is not pregnant. So this is a very simple checklist available on the Government of India website again. The question then comes, that is COC safe? We have already said that we must wait for 6 months in a breastfeeding woman. That will make it safe. Okay, the risk of venous thromboembolism is paramount in the first 3 weeks, and this is when even in a non-breastfeeding woman, you avoid the oral contraceptive pill in breastfeeding throughout the 6 months, because it may impact the quality of breast milk. And we can start for breastfeeding women as early as 6 weeks with the progesterone only pill. The question then comes, can we insert a postpartum IUCD? So it must be understood that it is a very, very suitable method for contraception, because it covers contraception along with delivery. And the few contraindications are when there is unresolved postpartum hemorrhage, or there is infection, or there has been a PROM of more than 18 hours. Otherwise, there are a few category 3 which apply to non-pregnant women, like active infection or malignancy or trophoblastic disease or AIDS, but not in an immediate postpartum. The immediate postpartum categories, as I spoke, is category 4, the 3 I spoke. The category 3 is between 48 hours and 4 weeks, and prolonged ROM more than 18 hours. No category 2 is identified for PPIUCD, postpartum IUCD, and category 1 is all the remaining women. So large number of women are eligible for PPIUCD, including those who undergo cesarean section. Immediate post-placental, postpartum within 48 hours, post-placental is better. If we miss this, then we have to offer it after 4 weeks. So a very nice checklist here by USAID and by NHM, again available on the website. Please download and keep. Just look out for unresolved hemorrhage, infection, or ruptured membranes more than 18 hours. Otherwise, PPIUCD can be done. Can we start a the POP pill, progesterone only pill? Absolutely, it can be started as early as 3 weeks, and we have desogestrel, we have drospirenone, and these are the 2 pills now available, in which the desogestrel pill-free interval is 12 hours, whereas for levonorgestrel pill, which was earlier available, is 3 hours. And now that means the missed pill interval, and now with the drospirenone, it is 24 hours. So better and better progesterone only pills are now available, and it is very effective. and it can be given continuously 28 days with no pill-free interval. When we give desogestrel, when we give drospirenone, we can allow one bleed to happen after every 28 pills. Now, the POPs are underutilized and very favorable for postpartum because they do not affect the quantity quality of pill. So, as I have been speaking about drospirenone 4 milligram, almost all women who are postpartum, post-abortal, or even those who have medical conditions or they smoke or elderly or have had anemia, etc., can use. And day 1 to day 24 they can take, and four pill-free periods can be there, and this is how it looks. It is a very good method, and we need to become a little more familiar with this in order to prescribe it. And I told you already that the missed pill interval, if she remembers within the next day, there is no need to use any other method. She can just continue the pack after taking the missed pill. What is the role of non-hormonal methods? Well, there is a significant role, and you can see that the color of the wheel has changed, and this is the new wheel by the Government of India. And you can see the methods here. You will be able to see that there is a centrochromen pill, which is known as Chaya, and it is category 1 as immediate postpartum contraception. So PPIUCD, centrochromen pills, all can be given immediate postpartum. You can say that only the injectable and the COCs are not okay. Other methods are okay, including the implants. So immediate postpartum contraception is a wonderful, intervention to have. So this is what I discussed already about postpartum. So ACOG and WHO agree that women who are breastfeeding should not use COCP, which I have already told, combined pill. And if possible, they delay the use of COCP till 6 months because of the impact on the. What are the pros and cons of sterilization? So you can provide postpartum sterilization under ACDS. They accept the caution in certain conditions, delay in certain conditions, and special. So caution may be in a case of heart disease, delay in a case of anemia or some infection which needs to be corrected, or special when there is more surgical scarring or there is more complexity like a diabetes, etc. So more care should be taken and tertiary centers should be opted. So sterilization otherwise is a very convenient procedure and should be done with enough counseling so that the chances of regret is not there. So implant is one thing which we all need to become familiar with, because globally it is a very, very popular method, and the subdermal implant has come here to stay. It is a very simple insertion technique. It contains etonorgestrel and lasts for 3 years and requires a very simple training procedure. It is single rod and it is inserted on the inside of the arm, okay, just under the skin. And it is a very simple insertion technique and removal technique, but requires training. And once the couple wants to bear children, they can remove it and rapid return of fertility is there. Some additional advantages that it reduces pain during period and also has some beneficial effect on the endometriosis, PID, etc. Does a male partner have a role in postpartum contraception? Absolutely. He can have a very good supporting role in whatever his wife decides to do, and also he can convince the elders in the family that postpartum contraception is all good, scientific and good for health, and he can attend the clinic along with the wife. And also, if there is no other option, he has to meticulously use barriers to prevent pregnancy, and also can get vasectomized whenever advised. There are some other pills which I think we will not take here. We will end with just mentioning the injectable, which I think is the woman's best friend because it's a very confidential method of contraception. 150 milligram every 3 months, dipomedroxyprogesterone acetate. And the good news is that the subcutaneous version is available, and it is a disposable one where the 104 milligram, a reduced dosage, may be with lesser side effects, will be very good. And then you can see that it is very versatile. Category 1 has so many medical problems, gynec problems, use of drugs also, anticonvulsants, antiretroviral therapy, anti-tubercular therapy, all of them are category means that means they can use the injectable. Category 2 is a little younger girl, adequately controlled hypertension. Category 3 is breastfeeding before 6 weeks postpartum, and if there is a major medical problem. And category 4 is only the one and only contraindication there is current breast cancer. So for HIV women, it has been eminently researched and found to be very suitable. What if there is no method acceptable? Then you can tell them about the barriers. You can tell them about the emergency contraception also. That also has its own wheel, which the European consortium has devised. And these are the situations where emergency contraception, where the couple does not use or has a broken condom or an expelled IUD or delayed IUD change, etc., or the delayed injection, etc. And then we have the LARC after giving birth, including the LNG IUS. Well, then I think that I am overshooting my time, but I must just say that even if there are mothers who have had deep vein thrombosis, or who have had hypertension, or who have had diabetes, or who have had cardiac disease, in all of them, it is possible to create a very, very safe basket of choice. So women who deliver and have some medical problems also should not be allowed to leave the hospital without having counseling about suitable contraception, because these are the mothers who are more vulnerable to pregnancy, in the sense more vulnerable to complications in pregnancy, and they should. So these are slides which go through SLE in pregnancy, and these are with breast cancer in pregnancy, etc. And we come to the question of, do you believe in integration of services? So integration means that you combine your antenatal care with adequate postnatal care, with contraception care, with vaccination and immunization, and also with HPV vaccination if required, with neonatal care and neonatal vaccination, etc. And so on and so forth. So integration of services is very important, and PPFP is not a vertical program, a standalone program, but it is an integrated part of existing maternal and child health and FP efforts. So it is comprehensive care, and be sure to provide it a lot of vigor and conviction in your practice. So integrating PPFP across contact points during pregnancy, in the labor room, postnatal care, and immunization visits. Unmet need at highest in the first year post-delivery, 65%, in spite of 95% of women delivering in the hospitals. And this is a unique period of life, adding more reasons for not using contraception. They are all the time afraid about the baby getting affected, etc. So our counseling becomes important, and spacing of 2 years at least improves the maternal and fetal outcome. So postpartum advice is A, B, C, D, and C is for contraception, B is for breastfeeding. You can go on and go on about this, because there's a lot of work to be done in postpartum period. We have our hands full. And remember that PPFP is not only 6 weeks counseling postpartum. It is a continuous process starting with pregnancy till 1 year post-delivery. Thank you for your patient listening. Thank you very much.
So thank you, Shobha Madam, for your elaborate lecture on postpartum contraception. So in South, especially in Andhra Pradesh, most of the people, they want only tubectomy bar laparoscopic sterilization following delivery, madam. So they are not following, in spite of our repeated counseling, madam. So what as a gynecologist for obstetrician we can do to promote the postpartum contraceptive methods? Even the government of India introduced Antara.
Yeah, and Chaya, both.
Yeah, yes, madam.
Well, work is not done is not sufficient.
Yes,
there is not even enough talk about contraception.
Yes,
there's not enough. I'll draw an analogy. A few years back, you just take about 7-8 years back, nobody knew what is a menstrual cup.
Yes,
Nobody
madam.
knew. But today, majority of the girls are familiar and they're liking it and they're using it. And that is because of the nationwide drive for menstrual cup, menstrual hygiene, of people like us who went on talking about it. And so I think more conversation needs to be there about breastfeeding, about contraception, about postpartum care as a very, very important health intervention. That is not highlighted enough. Unfortunately, most of our hospitals, even modern hospitals, do not elaborate this service. Their entire focus is on the delivery process, and that is where it all ends. So I think Foxians should change this, should bring about integration of services and highlight this fourth trimester. And I think Sneha is doing an excellent job by conducting these series of webinars. So I must thank you for the opportunity. Thank you.
Thank you, madam.
Thank you, Shobha. That was wonderful as always. And whether we have some comments from the chairpersons?
So I chaired the session, madam, because the other 3 chairpersons not available.
Okay.
And one more question, Shobha, madam. Oh, madam already left. Okay.
No, she's there now. She's there. She's there. I think you can ask the question. You can see in the chat box there is one question that, ma'am, even if menstruation is not started in postpartum period, can we put IUCD? I think Shobha should be from you. It's postpartum.
Madam, unmute, madam. Shobha, madam.
So it is important to rule out pregnancy in such cases because she is still amenorrheic. So it's important to follow the checklist which I told you, and then if necessary do a pregnancy test. One thing is that if the woman comes immediately after 4 weeks and definitely there has not been intercourse in that time, unsafe intercourse, then I think it's okay to provide her with a proper IUCD. But between 48 hours and 4 weeks, we will not be able to provide. That is for sure. Within 48 hours, yes, and after 4 weeks, yes. And be sure that she is not pregnant. That's all. It can be given.
One more thing is, madam, we introduce PPIUCD and they will go to some other doctor after 2 months or 3 months, either for checkup, and they will get it removed.
They'll get it removed. Yeah.
Yes.
So that is what we have to counsel. We have to bring in awareness about this method as a scientific method amongst our consultants also, because most consultants do not look upon it as a scientific method. They're not comfortable about it. So first we have to break that barrier. So there are a lot of barriers and hurdles in the way of providing this method as a postpartum contraception. Yeah. Yeah, thank you.
Thank you, ma'am.
That's before yeah, tell me.
Ma'am, you said female sterilization within 7 days or after 6 weeks.
Yeah, ideally, yes.
Why, ma'am?
Because
after 2 weeks, can't we go for
we can do, and it is being done also. I'm not saying that it is not being done. Delayed postpartum sterilization is being done in the government program, preferable within few days of birth, because there is less chances of the slippage of ligature, because there's a lot of involution, rapid involution after that. It can be done anytime, but preferable is what happens after the first week is, again, you may have to provide a mini laparotomy only. But if you wait another 2 or 3 weeks, because anyway she would have gone home, you can provide her a laparoscopy. Once she comes after a few weeks, you can provide her a laparoscopy. So that is one advantage. Immediate postpartum, unfortunately, we will not be able to give laparoscopy. We have to do a mini laparotomy. So there are some advantages. It's not that it cannot be done. It is preferable to do immediately after or after some time, like 4 weeks or so, when you can offer a laparoscopic sterilization very easily.
Yeah, madam. Okay. I worked in family planning department nearly 10 years in government service, madam. Yeah. We used to do a tubectomy up to 7 days following a normal delivery. Or if along with the cesarean section means we will do at the same sitting, provided other babies, the last baby is more than 3 years are healthy. So otherwise, we advise them to come only after 6 weeks.
Correct.
So
later on, yeah, surgical intervention is better to be later.
Laparoscopic tubectomy better after 6 weeks.
Or
so
even later, after 6 months is also.
Cesarean section, we used to do after 4 months, madam.
Yeah, after 6 months is what we advocate. After 6 months is what. Yeah.
So because in government setting, no, we advise them to come after 4 months only.
Yeah.
But we had some problems while doing tubectomy because the tubes are thick, edematous, getting lacerated.
Yes.
So sometimes needed laparotomy also. So your advice 6 months is better, madam.
6 months is better.
Yes, madam. Yeah. Thank you, madam.
Thank you.
Madam, immediately if you do the sterilization also, some regret will be there for the patients, ma'am. That is what given.
Correct. I agree with you. I agree that.
Yes, ma'am.
Yeah. Suprada, quite a few of you have joined. There is some technical, there's some technical problem wherein we are all,
Suprada, named
as Suprada. And the change of name, and change of name is not coming. So, that is one thing which is often not highlighted. That regret factor can be there. Yeah, regret factor. Your problem, your question was about regret factor, na?
Yes, ma'am. Regret is more if they do immediately after delivery, ma'am. They do sterilization. Yes, ma'am.
Yeah. So it is important to discuss during pregnancy.
Yes, ma'am.
Always discuss during. So suppose she is coming with a second cesarean. I mean, she is a previous cesarean. She is coming with a second or third pregnancy. And then, some couples feel that immediately, because another surgical intervention, better to get both done together. But then you have to tell them that you have an option of waiting till the baby grows up, becomes healthy, and you are convinced. This will be true, especially if she has delivered with a high risk, like preeclampsia, it's preterm or IUGR or something, FGR or something. Then you should encourage them to wait actually. So in high risk situations, you yourself can counsel that, see, even though it is the second cesarean, no need to be in a hurry. There are many LARC methods. So always promote LARC methods. And these are situations where you convert a sterilization seeking couple into a LARC couple. That means you insert a postpartum IUCD, intracesarean IUCD. So when you do the cesarean, you also place the copper IUCD. And also tell them that, see, if you have any problem, you come back to me. I will remove it for you. Don't go seeking removal from other people. And when they come back to you with good treatment of the symptoms, you will be able to continue at least in 50% of them. So it's worthwhile. We have done a structured study on PP-IUCD in about 7 hospitals. More in the north. You are all right that south doesn't accept PP-IUCD well. And we found very good continuation rate of about 65 to 70%, which is good.
Government institutions we are following, ma'am, but private institutions they are not taking the initiative, ma'am.
Yeah, I know that. They have to attend webinars done by Dr. Sneha Bhuyar. Then they will take up.
One last question, Shobha madam.
Yeah.
So, most of what happens is patients will have 2 cesarean sections. And they will come for contraceptive methods. Which do you advise better, madam? Because it is difficult for me most of the times to introduce any Kapati thing in previous 2 cesarean sections, especially.
But if they prefer a intrauterine device, then you have to provide it to them. There is no kind of, there is no contraindication because it is a
sometimes it is very difficult to.
So there are some techniques of making it easier. One is that you can ask them to, come immediately at the end of the menstrual cycle. That is one thing. And we can ask them to use misoprostol the previous day, not on the same day, though all this is not documented anywhere. But misoprostol can soften the cervix a little bit. Better still, we try to reassure them without any medication, reassure them end of the menstrual cycle, maybe the 5th day, and we do gently a sounding of the uterus. And if the sound goes with good lubrication, we place the IUCD. You can choose IUCDs which have thinner diameter, and they are not the copper IUCDs of the government, the multi-loads, they are more flexible, thinner, and they will go inside the uterus easily, through the cervix easily. So choose the proper IUCD, which is very flexible and soft, and that one can be put. Okay.
So if it is not possible to put that IUCD, can we go for Antara?
Yes, you can go for that, or you can also go for implants. So please learn about implants and become good in that, so that you can provide the method, because
implant training is given where, madam?
Implant training was given in the government last year. Now government training is, I don't think it is going on, but private Organon is still conducting in batches. So
no training for implant.
We can do it. We can do it in small batches. Okay. All right. Okay. Thank you. Thank you.
Sneha, madam.
Yes. I think Monica to introduce.
Yes, ma'am.
Who will be introducing the panelists? Please go ahead.
Thank you, Shobha ma'am, for an excellent presentation and clearing all the doubts which our delegates and our chairpersons had.
Thank you, Monica.
We now move forward to the panel discussion on barriers in breastfeeding. Our moderator for today is none other than Dr. Sneha Bhuyar, madam. She has been the past chairperson of the breast committee herself. Our experts for today, Dr. Mangalavani, madam. Can we have the next slide, ma'am? Ma'am has already been introduced, Saiti. Dr. Mangalavani, madam, has been the past president of the Breastfeeding Promotion Network of India, Maharashtra. She's also the executive vice president of POGS, the treasurer of MSR Maharashtra chapter ISAR. She's also the course director of the BLC lactation training and the national trainer for ISCCP. We welcome you, ma'am. Our next expert for today, Dr. Aruna Kumari, madam, was the first in university in final MBBS, and she's the associate professor of GSL Medical College Rajamundry, a senior OBGYN consultant at Harshraj Hospitals. Her areas of interest include infertility and high-risk pregnancies. We welcome you, ma'am.
Thank you, Monica. Thank you for your kind introduction.
We now move forward to our panelists. The first panelist is Dr. K. Lalita Shristya. She has completed her post-graduation from SV Medical College, Tirupati, and she's got the Best Paper Award presentation in ICOG 2015-16. She has participated at faculty at various conferences with a vast experience of more than 17 years. We welcome you, ma'am. Our next chairperson is Dr. Baby Shalini, madam. She's a consultant and managing director at Shrista Hospital. She's currently the secretary of the Chittur OBGYN Society, and she holds a certificate course in contraception in GDM. We welcome you, ma'am. Our next panelist is Dr. Pandala Sarvanti, madam. She has a fellowship in minimal access surgery and an assisted reproductive technology. She has been working as a former assistant professor in ARI Medical College, Guntur, a former fertility and reproductive medicine consultant at Matruchaya Fertility Center, Nellore. We welcome you, ma'am. Our next panelist is Dr. Anita Shrikant, professor of OBGYN at VMBSC. Her special interests include infertility and high-risk obstetrics. She has a vast teaching experience of more than 18 years, and she has completed online certificate courses of IUI from Birla IVF Center. We welcome you, ma'am.
Thank you, ma'am. Good evening, ma'am.
Good evening, ma'am. Our next panel is Dr. Vignata Natulapati. She's a clinical director of Vignata Fertility and IVF Center at Guntur. She holds a fellowship in reproductive medicine from Milan, Bangalore, and she's been awarded prizes for paper and poster presentations in national and international conferences. We welcome you, ma'am.
Thank you, Dr. Monica.
Our next panelist is Dr. Shrisa Chavan Devakonda. She has graduated from ASRM Ilaru, and she's a postgraduate from Alameen Medical College. She's currently working in Apollo at Nellore, and she's been awarded the first prize of paper poster presentation in the Karnataka State Conference. We welcome you, ma'am.
Thank you, ma'am.
Dr. Grande Sodharani, madam, is from Kurnool OBGYN Society. Her keen areas of interest include infertility, colposcopy, laparoscopy, and high-risk pregnancy. She is the associate professor at GMC Nandya. We welcome you, ma'am.
Thank you, ma'am.
Our next panelist is Dr. Suprada Kotopalli. Ma'am, she has an experience as a senior resident at SVC Vijayawada for the past 1 year, an assistant professor at NRI Medical College 2016 to 22. She has presented various papers at the Mumbai and Ahmedabad conferences and won the second prize at the AIPCOG NetKelly conference. We welcome you, ma'am. Over to you, Sneha ma'am, for the panel discussion.
Yes, thank you so much, Monica, for that wonderful coordination and the introduction of our panelists. Thank you, Dr. Radha and Dr. Devishri, for the wonderful coordination. Of course, thank you all the society president secretaries once again. So, without much ado, we would go ahead with the panel discussion. Let me just share my screen. I hope you can see my screen, and now it is full screen. Okay. Can you see the screen? Yeah. So once again, I welcome our expert, Dr. Mangala Vani, Dr. Aruna Kumari, and I welcome all of you, my dear. So without much ado, we would like to go ahead with the panel discussion straight away. I'm sure this is a little different topic, not regularly discussed with all our scientific sessions, but that is why it makes it more, interesting. So all of you know what is breastfeeding and how it is initiated by now. All of you are following all the recommendation, but it may be just a quick revision to all of you and, sharing your experiences as well. So friends, that breastfeeding is actually the feeding of the baby directly on the mother's breast. And this breast milk is very, very specific to human species, and it is rich in nutrients, the appropriate nutrient component in appropriate proportion. That is what it is available at the appropriate temperature, taste suitable to the baby, and of course, easily digestible. And there are so many other advantages, right? From, that it protects the baby for not only from the sudden infant death syndrome and the immediate problems, but also the long-term problems of, right up to the protection from having the other respiratory and GI illnesses, and lots and lots of malignancies, including Hodgkin's lymphoma, etc. And of course, the intelligence quotients, which is the most important. So all of you know that it's really very, very beneficial. And that's the very reason we should, insist that the mother does the breastfeeding and the way it is recommended. So I would ask the first panelist, what is the oxytocin reflex, and what are the factors that can promote or hinder the oxytocin reflex? Can we? Yeah, please go ahead.
Thank you, ma'am. Ma'am, this oxytocin reflex is when the baby start sucking the breast of the mother. So
Yes.
it is a conditioned reflex. The neurons from the nipple, it will be afferent neuron transmit the information to the hypothalamus. So that is stimulated. From there, the hypothalamus, it will come to the pituitary. So from the pituitary, the hormones are released like pituitary hormones, prolactin and oxytocin. This oxytocin from the pituitary, it will come, the efferent neurons will reach the alveoli. So in the alveoli, already the prolactin action will be there in between the breast feeds, because this prolactin makes the alveolar cells to secrete the milk, and it is stored in the alveoli. This alveoli is covered with the myoepithelial cells. So this oxytocin will reach the cells and it will make it to contract. So the ejection of the milk will occur through this oxytocin. So this is the this is the conditioned reflex. So whenever whenever the baby sucks the mother breast, it will activate it, or when the baby, the seeing at the baby, or the listening the crying of the baby. So this reflex gets activated, ma'am.
Okay. So I would just ask you in short, which hormone is responsible for the milk production and which hormone is responsible for the milk let down?
So prolactin is responsible for milk production, and this oxytocin is responsible for the let down of the milk.
Yeah. And in which half of the day or which timing of the day the milk production is maximum?
So during night time, the prolactin levels will be more, ma'am.
Yes.
So the milk production is more during night.
Yeah. So why are we worried so much about this, oxytocin reflex immediately after delivery? What is that, that hinders the reflex that is more worrisome?
So because this oxytocin will help in another way to the mother. So when we start breastfeeding the mother immediately after delivery, this release of oxytocin will cause involution of the uterus also.
Okay.
So in that way also this oxytocin is helpful. And the bonding between the mother and the baby starts if we allow the mother to feed the baby immediately.
Perfect. So if she is having, some sort of pain, worry, anxiety, or doubts, lots of queries in her mind, that will hinder her reflex, right? So,
Yes.
what are the what are the different types of breast milk you know of? We can go to the next panelist. And what are the reasons for inhibition of breast milk secretion, in initial few days? The next panelist we can have. Yes.
Madam?
Yes,
Hello.
yes. Dr. Sudharani, you can take up this.
Madam. Actually, immediate postpartum, it is mainly because of the pain, anxiety, and if at all, if there is emotionally disturbances present from the house, like husband or else from the in-laws.
Yeah, but sometimes suppose she is
disturbances.
getting initially she is getting good milk secretion, but now there is further problems in getting the milk secretion. So now what is the reasons for this? She's getting good secretion, her breasts are engorged.
Okay.
But now, yes, tell me.
It may be because of ineffective milk production because of improper latching.
Latching, perfect. And?
Or else the position of the baby. Or else any like cracked nipples.
Yeah.
And this full breast that is getting, compressed.
Engorged.
Yeah.
Engorged breast
of the
will
breast.
hinder the production of prolactin and it causes less production of the milk, ma'am.
Okay.
When the alveoli are full of milk and breast is getting enlarged, then the production of milk is hindered. So,
right. And what are the different types of milk Yeah, till the regular breast milk comes, what are the different types of milk? What is the transition through which
it's a colostrum. It is the first milk that is produced during the pregnancy itself in multigravida and also up to 4 days after delivery. It is mainly rich in proteins and antibodies. It is rich in immunoglobulins also, which helps in good digestion for the fetus, for the infant, and also it protects the gut from the infections, external infections also. And also the followed by transitional milk. It is produced from day 4 to 10, madam. But it is lower in protein in comparison to colostrum. Mature milk is produced from approximately 10th day.
Right.
Until termination of breastfeeding.
Yeah. So Dr. Shalini, Dr. Baby Shalini, do we have Dr. Shalini?
Good evening.
Yeah, good evening. So, what are the reasons for inhibition of somebody has already talked about the improper latch, inadequate secretions and, all these reasons. What do you feel? Any addition from your side? When the breast is engorged, what happens? Lots of milk, then still the baby cannot feed. So, what is the reason for that?
Improper positioning of the baby is the first reason.
Right.
And the baby won't take the milk and she won't.
Status of the mother.
Hello.
Hello.
Yes, tell me. Go ahead.
When the breast is engorged, the baby pressure, there will be poor attachment, latching.
Yes.
The milk will not let down, and the mother is pain. Again, the let down is inhibited.
Right.
Because of the pain.
Okay. So, what is the reason because of which there is poor attachment here, especially?
First of all, the counseling to the woman, madam.
Either sore nipples, cracked nipples, or the mother is not at lack of confidence.
And also, she is not experienced. Yes. Okay. If at all,
inexperienced mother, or the family tries to feed with the bottle one.
Right. if she's, you have
try
that
to get a
misconception.
bottle.
You have that misconception that, this milk will not be sufficient for the baby. The milk may not be there for the first 24 hours. And, that is how, so actually you have to rule out, or you have to actually negate all these inhibitions. It is said that, the first moment when the baby suckles at the breast, the milk starts coming down. Maybe it may be just few drops or so, but it is so concentrated that it meets with the energy requirement of the baby. Okay, so there is no question of giving top milk. So if at all you are giving bottle feeding and the mother is not well experienced, there may be some problems with the nipple and also the lack of skilled support. All these things will make it difficult for the mother, or to feed the baby, and it will add to the difficulties. So I would just take experience or expert's opinion. Dr. Mangala. Mangala? Is Mangala here? Yes, Mangala.
Yes, I'm
So
here.
I want you to speak on this, how you have to, negate this point, that how you should initiate it at the earliest, and how we do it, how we follow. Please share with the panelists and the audience.
Thank you, Sneha, for the invitation, basically. And this is a beautiful topic that you have chosen. And this is a very important, that the barriers, particularly the initiation of the breastfeeding or to first few days after the delivery. Because the common concept all around is that the milk is very less and it is not enough for the baby. But the nature is made like that. And the milk is less, but at the same time, the baby's stomach is also very small size. So even if that colostrum is small and in amount, even few drops, it is enough for the baby. And another thing is, when baby is born, baby has enough glycogen stores in the liver. So if the baby suckles very often, very frequently, automatically there is this glycogenolysis and the baby's glucose is maintained. And by third day, then if the baby is sucking frequently at the breast, automatically her milk supply also increases. So this is for the term baby, of course, not for the preterm babies. So even if the milk is less, the colostrum is less, the frequency that, we suggest actually every 2 hourly in first 10 days and then on demand later on. And the proper latching, is there an effective milk transfer from mother to the baby? So that we have to see. So we have to watch for that. What is the baby's urine output? How is the baby's stool? And what is happening to baby's weight? These are the 3 important parameters on the day 3, then at the day 7, day 14, and day 28 that we have to follow. So while in the hospital, if you weigh the baby every day, then you will know there should not be more than 8% or maximum 10% of the weight loss of the baby, or the baby's stool pattern should change. So by the time the baby's day 4 or 5, the baby's stool should become the yellow color. It is a meconium, the black color to start with. So it becomes greenish and then the yellow. On day 4 or day 5, if it has not become yellow, then it is just something to worry. And also the urine output. Now, first day, baby may pass only once, but then slowly the urine output increases. So by the time baby is 5 or 6 days old, baby will pass more than 6 times the urine in 24 hours. So, and after day 7, the baby's weight also starts increasing. And by the time baby is 10 to 14 days old, the baby's birth weight comes back to the baby's weight comes back to the birth weight. So, these are the important parameters. If the baby hasn't even passed the stool on the day 3 or day 4, that is something to worry. So we have to really closely monitor. We just can't tell the patient, you just breastfeed the baby. No.
Yes, yes.
You have to make
you have discussed it very well, and we will have your inputs in between still further. Dr. Aruna, any point from your side you want to add?
Yes, madam. One thing,
Yeah.
we should start skin as early as possible. The skin to skin contact between the mother and the baby as early as possible.
Yes. So that is what
Uh,
I wanted to,
and
yes, yes.
we should start the feeding as within 30 minutes if possible, or within 2 hours at any cost.
Yeah. So let me
And
clarify, are both the experts have added very valuable and valid points. What Dr. Mangala has discussed, with you, first and foremost, remove all the misconceptions, that maybe the mother doesn't have milk and the milk is not sufficient for the baby, and so you give top feed. That is in fact not needed, and it is a wrong practice. What is recommended by WHO, UNICEF, Government of India, everybody, that the moment you deliver the baby, whether it is by vaginal delivery or by cesarean section, you deliver the baby on mother's abdomen, and even before cutting the cord, you let the baby crawl towards mother's breast, let the baby get attached to the breast on its own, and let it feed on its own. That is what is even advised by Government of India. That is called as mother's absolute affection, the Ma initiative. That is one. And secondly, maybe you feel your pediatrician friend is, telling you that your baby is, losing weight. That is not a fact. In fact, there is what is called as inevitable weight reduction. 10% of the baby's weight is lost in first 10 days, whether the feeding is adequate or no. And that is why you should not get worried about the weight loss. Thirdly, the glucose levels of the baby are maintained, because even if you have little amount of cholesterol, that is sufficient because it is rich in carbohydrates, rich in proteins and calories, and also the babies has adequate glycogen stores. Okay. So even if you just keep on feeding the baby every 1 to 1.5 hours, and maybe few drops are coming, that is good enough to maintain the baby's sugar levels and to maintain the baby's physiological functions, the stools and urine output, what Dr. Mangala has talked about. If the baby is feeding well, if the baby is, sleeping well after every feed, that is good enough, and that is how you know that baby is passing urine for 3 to 5 times a day at least, and and maintaining the healthy healthy routine. That is what is good enough. That tells you that the breast milk is sufficient enough. So with this, I think we stop the discussion here. Now we go to what are the different breastfeeding positions. With the other next panelist, I think we can have it from Sirisha, Shravanti.
Yes, ma'am. I'm Dr.
Yes,
Sirisha.
Dr. Shravanti and Dr. Sirisha, from you, we want to know what are the different positions, and if you can describe, please let us know, and whether she can feed in lying down position, what is the problem?
Yeah, ma'am, we have 5 different positions. I mean, breastfeeding positions. The most common one is the cradle hold, and the and then we have 5 position: cross cradle hold, and then football hold, and then Australian hold, and then side lying position.
Okay.
Immediately after delivery, after cesarean section, and after normal delivery also, due to perineal pain and all, the mother can feed in side lying position and during night times. But the most common position usually the mothers will practice is the cradle hold, and some people will practice the football hold also, ma'am. And there is 2 concepts like good attachment and then poor attachment, ma'am.
Yes.
So for good attachment, we have to guide the nipple and the areola into the baby's mouth for effective milk transfer.
Right.
And then there should be proper positioning for milk transfer.
Yes.
And there should be contact between the mother and the baby. I mean, chest to chest contact. It should be maintained. Yes.
Yeah.
The good attachment means infant's mouth is wide open and then chin touches the breast. So it's very important to have the good attachment.
Right.
Yes,
Even
ma'am.
so, in short, you have covered everything. Only thing is, how should be the mother? She should wear a comfortable apron, and she should expose her breast to the baby completely. It should not be through a small chain and just give the nipple. That should not be the practice. Actually, her skin should touch the baby's skin. That is one. Secondly, she should be sitting comfortably with the backrest, if at all she is sitting, and the baby also should be in a comfortable position, like the baby's mouth, umbilicus, everything should be in one plane. It should not, baby is lying supine and you are trying to turn the neck. So it will, twist the neck and the baby will be uncomfortable. So you have to take care of all this. Okay. So now we go ahead with what are the problems now, what we have already discussed. So we go ahead with do you think that there are any contraindications to breastfeeding? Yes, Dr. Sirisha?
Yes, ma'am.
What
Definitely.
can be?
There are few contraindications for the breastfeeding, ma'am.
Like
infections like HIV infection. And
is it a contraindication, you feel?
Actually, in developing world, it is a contraindication for developed world. But in the developing countries, rather than the benefits of restraining the
if the mother is on treatment, if she's already on treatment, you feel still it is a contraindication?
No, madam.
No,
Galactosemia is one of the
galactosemia is also a
metabolic disorders.
contraindication.
Adult T-cell lymphoma is the contraindication.
Lymphoma, malignancies, who
And
are
local infection on the breast, this herpes infection on the breast is also a contraindication.
Yeah, that too, it is a temporary or relative contraindication.
Yes.
And what you said, if the mother is not on treatment, if the HIV positive mother is not on treatment, again, it is a relative contraindication. What about tuberculosis, you feel?
Ma'am, tuberculosis is also a relative contraindication, ma'am.
Yeah, so if it is an open tuberculosis and she's not already on treatment or she's still positive, sputum positive, then it is a relative contraindication. But yes, with appropriate treatment and the proper hand and respiratory hygiene, she can feed her baby. Okay, the messages should be very, very clear to all the audience. So thank you so much, all of you. Let us go ahead with short, quick cases. Here you have this, Mrs. XYZ, low risk primary patient. She just delivered today, and now she started breastfeeding. You are after her to, start feeding. So suddenly she finds that there is a blood stain discharge. So Dr. Sudharani, how will you proceed to counsel her, to guide her, and to investigate her?
Madam, first of all, from the history, whether it is unilateral or bilateral,
right,
or associated any cracks or ulceration,
okay,
or any other lumps,
right,
present. So on examination, we'll be confirming our findings.
Okay.
And there is a component called as a rusty pipe syndrome, madam.
Okay.
Which is a physiological one seen only in 0.1% of the patients, pregnant, puerperial woman.
Okay.
Where because of the excessive vascularity of the ductal and alveolar region, there will be secretion of milk associated with blood staining.
Right.
And this is self-limiting, and it limits itself within 3 to 7 days, or else within few weeks as the breastfeeding continues.
Right. So you have to, so your role of counseling is very, very important, right?
Yes.
So once you have to first rule out the serious possibilities, and then you counsel her. So if it is, there's no associated lump, and if it is just it's coming little amount from both the sides, it's, nothing to worry. If you have a localized lump, and of course, then maybe it is coming continuously more and more from one side only, then that needs to be evaluated, like you have to go for ultrasound and of course the cytology of the discharge. I think that should be all. And the rare ones, you may have to go for galactography and rule out the duct papillomas as well. Okay, now once you rule out everything, it's your duty to counsel her that everything has been ruled out and it is simple, physiological, natural. You have to continue with the breastfeeding. It will disappear on its own, correct? So I think that should be all for that case. Now, Dr. Baby Shalini, we have this patient, 32-year-old primary, delivered 10 days back. She reaches to your hospital, with complaints of pain. And she also claims to be having difficulty in breastfeeding. What can be all the causes for this, and how will you proceed?
Yeah, this is a very relevant question, ma'am. Just now, some time back, I had a patient just delivered 10 days back, had a normal delivery, and she came with complaints of pain in the right breast from past 4 days. So the family is telling her, need to go to the hospital, it's normal pain. So with difficulty, she has reached the hospital.
Okay.
So then when
What
I
was
examine the
reason
breast,
and
it is
what could be
fat.
the reasons? Yeah.
So I was thinking of one is engorgement of the breast.
Mm-hmm.
And the patient herself told that right side is hard and the left side she had an inverted nipple. I mean,
right.
retracted nipple. So she was saying, and she was trying to syringe and all, removing this. The left breast is soft.
Mm-hmm.
And the other things we can think of is because for the pain, cracked nipple or sore nipples.
Mm-hmm.
And the next stage, if you don't treat the engorgement, then it can land up with either mastitis and next stage is breast abscess.
Okay. How do you
So
say? Now, so you're saying that flat nipple, crack nipple. So, Dr. Shravanti, do you feel that if the patient has nipple like this, she cannot breastfeed the baby?
No, ma'am, nothing like that.
Mm-hmm.
If we squeeze the areola, if the mother's nipple retracts, means it is called the inverted nipple, ma'am. Usually, inverted nipples are very rare. A flat or normal
Mm-hmm.
nipples will protrude, but the inverted nipples will retract. But we
Okay.
have to counsel the mother, and then we have to build confidence, and we have to help her positioning in different positions.
Okay.
Usually because babies will attach to the breast but not to the nipples, so babies will suck the breast and breast at nearing the areola also. So
Right.
we have to guide the mother, we have to give confidence and then
Perfect.
alternate positions for her.
Yeah.
And just before feeding also she can use alternate methods like syringe
Manual
and then
correction.
or nipple puller, or she can use the breast pump, ma'am. And
Yeah.
she can also use the silicone nipple shield as last resort.
Yeah, right. You're very correct that the baby, attaches to the breast and not to the nipple. It's not, that shape, nipple shape is required. The baby should attach to that particular portion. So I think that should be a very, very important message from our side that, if at all the mother has these kinds of nipple abnormality, it is just the change of position, helping her to go for proper attachment, giving her the confidence that over the period, baby's mouth is the best pump you can have, and it will shapen up the nipple over the period of time. Okay. So, Dr. Shirisha, we come to you now. We have this Paravan delivered 5 days back, and she comes to you. She was discharged because normal delivery. Now she comes to you because of fever with chills and tight breast, shiny nipple, very painful. And when you try to squeeze, there's no milk flowing out. So, what is this condition, and how do you go ahead with the management?
First, we should examine the breast, ma'am.
Yeah.
The tightness of the breast will be there.
Yeah.
And
that we have given you, that this is what is the picture. And yes, there is engorged, shiny, breast.
Shiny breast, but there is no redness, and also it is just an engorgement of the breast. It didn't go to the mastitis yet.
Yeah.
And usually the causes of engorgement will be that delayed initiation of the feeding, and there will be poor attachment by the baby, and infrequent removal of the milk, and restriction of the length of the feeding, ma'am.
Yeah, yeah.
So,
some people say, you feed for 10 minutes, 20, 15 minutes. So nothing of that sort. It should be a complete unrestricted feeding till the time the baby fits and, baby stops on its own. That baby leaves the nipple and the breast, then you should stop feeding. Okay, that is what is the message. So how do you treat? How do you correct all these problems?
So we should empty the breast regularly, ma'am. So the early initiation will help. Good attachment will help the emptying of the breast properly, and frequent removal of the milk manually. If the mother feels there is still excess milk after the feeding gets completed, that is baby felt it is the completed, and encourage unrestricted breastfeeding, ma'am. Like there is no die-hard rule to time the feeding sessions, ma'am. Like she should feed every second hourly only or something like that. So that should be like a on-demand feeding, ma'am. As ma'am priorly said, at least after 10 days, that should be an on-demand feeding so that the breast will be emptied frequently.
Right. So suppose if the baby is, with the mother, you can definitely encourage her, relax her, you give hot fomentation, attach the baby, and you, even after, feeding the baby, you give cold compress. But if the baby is not with the mother or baby is sick, cannot suck, then what will you do?
Then we can encourage the mother to give expressed milk also, ma'am.
So how should she express that?
There is two methods. Manual expression can be there, or there are instruments like these breast pumps, which
Okay.
can help the mother to express.
How do you do manual expressions? All of a sudden you go and squeeze the breast, or how?
No, ma'am. First, we have to massage the breast gently and then check the position of the fingers to squeeze the breast, and then be gentle on the patient and squeeze the breast, ma'am, to express manually.
Okay. And
There
suppose
are breast pumps which are manual and automatic. Both types are there. They can help the patient to express, ma'am.
right. And before feeding, if she has a hot or warm shower, or if she uses hot compresses, that automatically helps in milk let down. That helps her.
Letting down.
And
ma'am.
also because of hot fermentation, she will have less of pain. Okay. And cold compression. You can see, this cabbage leaves, if she applies, it gives you a very fantastic pain relief. Okay.
Yes,
We go to the next panelist now, and can we have the spot diagnosis? What is this? These two conditions.
Nipple, ma'am.
Yes.
Usually this sore nipple will come.
Dr. Vignata. Do we have Dr. Vignata?
Yes, ma'am.
Yeah, please go ahead. What is this?
So this is a condition of sore nipple, ma'am. It is seen in cases where the baby is not able to latch properly. And sometimes this inverted nipple or cracked nipples may also cause this condition.
Right. So how do you treat this?
So in these cases, we should not ask them to stop
I'm sure you must have seen such cases, the mother just refuses to feed, or she just starts crying when you want to, you tell her that, no, you have to continue, and she starts crying, So that is how it is. So how do you go ahead with the counseling and further continuation of breastfeeding?
We should actually build up confidence in them that this is not a big problem, and we should counsel them. And also the support group, like the parents or the husband, also should be counseled that they should build up the confidence for her. And also
you are analgesics.
Yeah, we have
analgesics, your hot compresses. Yes. And
the compression. And also after every feed, we can just ask her to put some nipple creams, and before the next feed she should wash them with water and then give it the feed to the baby, so that it will help her.
Okay. It is, said that maybe most of these nipple cracks, they heal on their own, rather than applying some creams, or maybe just washing it, frequently. That may even worsen sometimes, because every time she's rubbing it out. Okay. So what is recommended is, when she feeds the baby, let the milk air dry on the nipple. Okay. In fact, maybe way back around maybe 2-3 decades ago, even we used to tell the mother that, frequently you wash and dry. But nowadays the practice is that you let the breast milk, air dry on the nipple. Okay, and that's the best healer. Okay. So you help her in continuation, and of course you do apply, if at all it's such a bad wound, maybe you have to apply some local ointment, right? Local antibiotic ointment. Okay. Now see, I think whom do we have now remaining? I think Suprada and Anita. We
Yes,
want
ma'am.
your opinion.
Yes, ma'am.
Suppose sometimes you find that, that mother is either having this kind of breast, that upper one, angry red, it's very easy. But sometimes, the breast is almost normal looking when she comes to you. You find, she's all the time saying it is very stinging, penetrating pain, and, burning and stinging after every feed, and she starts crying. But when you examine, you find neither engorgement nor any lump, and even everything looks like normal. So what is this condition?
Mostly fungal infections, ma'am, due to lack of proper hygiene immediately after delivery.
So either the mother has a fungal infection, or the baby's, mouth has a fungal infection, oral thrush. Right.
Oral thrush, mostly candidiasis, oral thrush for the baby, or the mother may be diabetic, having any fungal infection before prior to delivery.
Right. So how do you treat this kind of infection?
Usually first we'll advise a proper hygiene, antifungal topical cream before the breastfeed, and ask her to wash while during breastfeed.
Okay. Not systemic antifungal for the mother?
which are
Now she's not
safe will
pregnant.
advise.
It is,
Yes, we can give oral antifungals also, ma'am. Mostly antifungal creams, or any oral fluconazole tablets, maybe for a period of 1 week, or based on the severity of the infection, for 1 to 2 weeks, we can give topical application of antifungal creams. We will check for whether she's having any vaginal infections, vaginal candidiasis.
Yeah.
We'll rule out.
And if the baby has a oral thrush, you will treat that. Okay.
Yes.
So, and somebody has already talked that, that patient, who is having only engorgement and there is no redness. But now this lady, maybe she failed to come to you, and after a few days she comes with this picture. What is this now?
This is a mastitis, ma'am.
Okay. How do you go ahead with the treatment?
First, we'll give check whether she's having any infections, any lymph node enlargement. Then ask whether she's having any fever.
Fever with chills. She's coming to you with fever with chills, breast pain. When you examine, that area completely is red, hot, tender, but there is no lump as such. Okay.
Then we'll give hot compressions, analgesics. If there is any severe hot compressions, cold compressions meanwhile, and analgesics to reduce the pain.
Antibiotics we have to start.
Yes, antibiotics also will start.
Yes. Okay. So, Dr. Suprada, we have to continue breastfeeding, otherwise, this engorgement will go to mastitis and it will lead to, breast abscess. Okay. So,
yes, ma'am.
We have already discussed all these aspects, so I'm just skipping. Which antibiotic you will prefer in this patient? Dr. Suprada, I would ask you.
What?
Do we have Dr. Suprada? Yeah, you have already discussed. I think Vignata.
Yes, ma'am.
Yeah, Vignata, we can.
Yes, ma'am.
Yeah, which antibiotics you should prefer?
I would prefer cephalosporins or amoxicillin, ma'am. That, I mean, most of the cases, maybe they would be reduced with that. And in some cases, clindamycin also we can give them.
What about ciprox, chloramphenicol, tetracycline?
They are contraindicated. They are contraindicated because of breastfeeding, ma'am.
Right. So, and what about clavulanic acid? Dr. Aruna, can we have your opinion on this? Aruna Kumari?
Management of mastitis, madam?
Yes, especially the antibiotics.
We should use only this amoxicillin, cloxacillin, and erythromycin. And what all you are mentioning, ciprofloxacillin and tetracyclines are contraindicated because the mother is feeding.
Yes. Any view on clavulanic acid? Have you heard that, it creates...
No, madam, it's contraindicated because there's higher chances for necrotizing enterocolitis in the baby.
Perfect.
So it should be avoided.
That is what we, especially in preterm babies. But, we can take this as a general dictum that clavulanic acid should be avoided as far as possible, during breastfeeding. Okay. So now we go ahead with Dr. Anita.
Yes, ma'am.
Yeah, so we have this 25-year-old lady, Paravan, who is undergone cesarean section 10 days back. And now she comes back to you with fever, which is painful lump in breast and severe throbbing pain in the left breast, okay? When you examine, you find she's febrile, there's tachycardia, blood pressure is normal. Right breast is engorged, left is also engorged and tender, but there is a localized lump of 6/6. That is red, hot, tense, tender, and fluctuating. What is your diagnosis and how would you go ahead with the management?
Ma'am, patient is having all the systemic features of infection, plus there is a lump. So most likely the diagnosis is breast abscess, madam. Fluctuating lump is there. So most likely the diagnosis is breast abscess. Suppose the sore nipple or the cracked nipple or the engorged breast is not taken care of properly, that is the reason of the breast abscess, ma'am.
Correct. Now, how would you go ahead with the management?
Ma'am, for this previously we used to do incision and drainage, madam. I had one patient for whom almost half of the breast was removed because of this abscess, like such a big abscess she developed. So, but now we have an option, like we can do under ultrasound guidance, taking a large bore needle, we can aspirate all the pus from the pus from the breast. So how this is helpful is this will like no admission is
whether
needed.
it will be, whether it is for small abscess or even for this big abscess, and whether you can do it at
even
a single setting or you require multiple settings.
Ma'am, this may require multiple sitting. If the patient is compliant, if she is ready to come, then it can be even big abscesses can be drained with this aspiration, ma'am.
Along with antibiotic, anti-inflammatory cover.
Along with full antibiotic coverage and anti-inflammatory coverage, madam. The advantage of this is she can still continue breastfeeding. There is no admission needed, like no separation of the child is needed. So this is more comfortable for the patient also. Like that pain of the incision and drainage is quite like it's morbid for the patient. So it is good for the patient also.
That is done under
anesthesia. It's done under anesthesia, madam.
Yeah,
and
but
it is
then
more painful.
The subsequent, the post-operative dressings, the daily dressings, you pack the
yes,
cavity, you know, that is
and
very...
she just cannot breastfeed from that side of the breast, madam.
Yes. So that is what we have to take into consideration. Basically, you don't require any surgery, no anesthesia, and you know that post-operative dressings and that messy things, you know, all these are avoided, and the lady is, you know, allowed to continue with her breastfeeding, because if at all she doesn't breastfeed, you know, she will develop abscess at the other side. Okay, so she has to continue breastfeeding so that, you know, she gets relieved of this breast abscess very soon. As you said rightly, if it's a small abscess, and with a single, you know, setting, she will be relieved of. But if she has multiple or multiple deep seated, you can go ahead with this ultrasound guided drainage aspiration. And if it is you know, large one, she can undergo multiple settings, because you know that breast abscess, there are multiple loculi. The surgeon, you know, they break it. So that is likewise, you break it with the help of this wide bore needle, and you drain all the pus along with the antibiotic and anti-inflammatory. So I think that should be all from this. Mangala is, you know, I'm very happy to have her as my committee member, because she has worked specially on this aspect. And by the time, I think maybe around 7 years ago, majority of obstetricians all over India used to go for, you know, incision and drainage. The moment they see the breast abscess, they used to refer it to the surgeon. So we give this credit to Mangala, because she is the one pioneer for this, you know, and she has a paper also, lots of studies she has. So Mangala, can we have your experience for this?
Thank you, Sneha, for that. Yes, and with the breast abscess, actually, with the aspiration now, it has become so easy to continue the breastfeeding. Our clinic in Pune is a referral center, and we have done more than 250 cases in last 5 years. And small abscesses or big abscesses, doesn't matter. Actually, the bigger size is easy to aspirate. And now we are doing even without ultrasound control. And as you discussed, sometimes we have to done multiple times. It could be 2 times, 3 times, 4 times, depending on the size and the response, you know. And we have 98% of our patients we have just treated by aspiration, and only 2 cases so far needed IND. So it is pretty successful, very easy. I think every obstetrician, we are all surgeons, so we should able to do that. You know, surgeons, they don't know anything about breastfeeding, and as you said earlier, lot of even breast tissue is removed, and the scar is very ugly at the end of the day, and there is a stoppage of breastfeeding because they cannot put the baby to the breast. They make the incision very close to the areola. So these all problems then we can overcome.
You know, sometimes because it becomes such a tedious procedure and such a miserable condition for the woman that she herself, you know, asked for lactation suppression. That is what used to happen, I would say, maybe a decade ago or so. But since last 10 years, we have not referred any patient to surgeon for breast management of breast abscess. So thanks to you as well, supporting this view. And I would just say now that the proper breastfeeding techniques, all of you, the recommendation, as I have already talked about, that initiation of breastfeeding as soon as possible. I have already talked to you, the mother's absolute affection. And then secondly, attaching the baby properly to the mother's breast and feeding the baby with proper technique, proper attachment, complete unrestricted feeding without washing the breast repeatedly. After every feed, you just hold the baby and burp little, so that with the suction, whatever air has come, the milk will settle down and the hair will come. So it will be burping that will help the baby to get relieved of the hiccups, the small amount of vomits, and even the cramps. The baby gets, that is how that also is a part of this breastfeeding. And it should be frequent, unrestricted, complete feeding, as we have already discussed about. And this should be continued exclusively. By exclusive, we mean not even a drop of water, because mother's milk itself has almost 90% of the water. So exclusive breastfeeding for first 6 months of age. Introduction of the complementary feeds after 6 months. That means the complementary feeds should be homemade, hygienically prepared, semi-solid, soft feed. Okay, it should be having good nutritional value. So that should be the complementary feed. And with the complementary feeding, the optimum breastfeeding should continue for 2 years and longer. That is what is the recommendation by WHO, UNICEF, NHM, and Foxy ICOG as well. So with this, we conclude this panel, and I would like to thank both the experts for adding value to this discussion, and all the esteemed panelists who were very well read and experienced as well. So I just take this opportunity to humbly, request all of you to vote for me, support me, and of course, at present, from all the president secretaries to nominate me from your societies to support my candidature as Foxy Vice President from West Zone. So I thank all of you, and looking forward for your support, and having some academic stations in future as well. So thank you so much, all of you.
Thank you, Sneha, madam, for this opportunity. All the best, madam. You are the well-deserved candidate, and all the best, madam.
All the best.
Thank you. Thank you so much. Thank you, Kumari. Sir, Venkataramana.
Thank you, madam. All the best. And kindly look our Radhalakshmi also. Help her.
Yes, definitely.
All the best, Radhalakshmi madam also.
Thank you. Thank you, Aruna.
Dr. Radhalakshmi and Dr. Monica as well. Thank you, Dr. Shobha, for joining back once again. And it was wonderful to have you.
I had never left, actually. I was there. I was listening to the wonderful panel, and a lot of learning points for everyday practice for all of us. And I think we learn with every session. And I think reinforcement is needed all the time. So you're doing excellent work, Neha. And may God help you to continue to work. Mangala, hi. Wanted to connect with you. Hello, Mangala.
Hi. How are you? Yeah, see, these are the programs Sneha is giving opportunities. So we are just increasing the awareness on the breastfeeding and different issues of the breastfeeding. So
I'm aware of your work. You are all doing extremely good work in this field, and I think it's very much required. And I think teamwork is very important.
Yeah. So thank you so much, Shobha, and myself. We were the most active chairpersons working together. So I appreciate your work also.
A lot of work, and we would like to continue to work. So from your respective societies, please nominate. Thank you.
Thank you so much. Thank you, everybody. Thank you.
Thank you.
Nice. Bye-bye. Bye.
Thank you, ma'am.
Thank you so much, dear. It was my pleasure. Thank you so much.
Ma'am, it was very nice, ma'am. We enjoyed the session, ma'am.
Thank you so much. Thank you. Thank you, dear. We would like to have some emergency obstetrics also sometime. Definitely. Please do vote
Yes,
for me.
ma'am.
I want to represent
Yes,
all.
ma'am. Definitely, ma'am. And all the best to
And
Radha
with all
Lakshmi
your
ma'am
friends.
also. Ma'am.
Yes. Thank you so much. Thank you. Bye-bye.
Thank you very much for
Bye,
making
ma'am.
us the part also, ma'am. Thank you very much, ma'am.
Thank you, dear. Thank you.
Thank you, ma'am. Sneha, ma'am. And
thank you, dear. Thank you, Devishri. So I
yes,
could see now.
and
Yeah. So
wish you all the best, ma'am.
thank you. Thank you
Thank
so much, dear. Thank you. Thank you for all your help. Special
Yeah, and, support to Dr. Monica, ma'am, and Radha Lakshmi, ma'am. So,
yes, I did say that. All the best to both of you. That's what. Okay.
yes, ma'am.
Thank you so much. Bye. Bye.
Ma'am, first time we are connecting with you live, but we watch a lot of your webinars actually.
Yeah. Thank you
Shobha
so
ma'am, Kiran sir, Pai sir. Yes, ma'am.
Thank you. Thank you, dear. Thank you so much. Yeah.